Colleagues, the NHS is vital to each and every one of us. As a doctor for 40 years and a GP for 30 years, I've been through several reorganisations of the health service. I have the greatest of respect for my GP and hospital colleagues and many NHS managers who've always strived to ensure the best possible patient care is delivered in spite of constant structural changes. As a Liberal Democrat, I firmly believe in increased democracy, localism, empowerment and choice. Therefore, I welcome some of the proposals in the Health White Paper, including increasing democracy, transfer of public health responsibilities to local authorities, abolition of strategic health authorities, and emphasis on local clinical leadership. However, I feel the proposed wholesale transfer of health service commissioning from PCTs to GPs is a significant risk to the stability of the NHS. The BMA, the Royal College of General Practitioners and the King's Fund have now all expressed concerns about the White Paper, and in particular GP commissioning and the speed of change. Let's look at those concerns. Replacing the PCTs with GP consortia. This could cause disruption and instability, especially where current arrangements are working well. It takes GPs away from delivery of care to their patients, and being the purse holders could change their relationship of trust the GPs have with their patients. There is evidence that some entrepreneurial GPs want to push ahead, but many are reluctant. A recent survey of doctors carried out by the BBC showed that nearly 60% did not want to become part of a GP consortium and do commissioning. However, all GPs must join consortia. How is this democratic or localism? And how are the patients of the reluctant GPs being given more choice in a consortium controlled by a few? Then there's the lack of detail and contradictions in the White Paper. Basically, 80% of the NHS budget would be handed over to what are small private businesses. Where's the accountability? The only formal requirements for governance are two specific officers, a finance officer and an accountable officer, who might be a GP. It appears at present that performance will be monitored centrally by the NHS Commissioning Board. There's no statutory role for local authorities in monitoring performance. The vagueness of this guidance in this area gives me great cause for concern about transparency and possible inequity. The amendment put forward today seems to suggest that a new management structure needs to be put in place, which sounds very like a PCT to me, with more clinical input. Yeah. So why on earth go through a very costly and disruptive change to achieve this? It is said that GPs have experience of commissioning by a fund holding. Not all GPs were fund holders, and not all were successful. GPs were only able to commission planned or clearly defined procedures. To facilitate this, generous management allowances were provided. Now, management costs will be cut by 45%, and at the same time, 152 PCTs will become 500 GP consortia. Total commissioning will include emergency services, which cannot be different for individual consortia at each individual hospital. There are already signs that without clear guidelines, Wirral GPs want to split into disparate commissioning groups of varying sizes with no coterminosity with the local authority or hospital. Therefore, the GP consortia have to come together as a super consortium in order to commission emergency services. Immediately, 2 layers of bureaucracy and several different bodies for the hospital and local authority to work with. The purchaser provider system, which was introduced 20 years ago, is being perpetuated. It isn't working. There's no evidence that it's produced a more effective and efficient service. In particular, transaction costs are high and data is poor. There's probably going to be increased privatisations, with GPs being able to refer to any interested organisation. Private management organisations may be brought in to run GP commissioning. However you look at it, colleagues, this is a complex change being carried out at great speed. While I've made clear that I support the principles and some of the specific detail, I'm asking for a measured approach to be taken to commissioning of healthcare over a reasonable timescale in order to avoid changes which might cause fragmentation of the health service or just reinvent the wheel at great cost and massive disruption?
This amendment is about the Coalition White Paper and the GP Commissioning Board, but most important, it is also about change needed. First, prioritise the White Paper requirements and then see what can perhaps be done without some of them. Next, identify top priorities of the board to secure joined-up healthcare. It must be of large size and coterminous with the local authority, so that both are working together for the same people. 2, the board must be self-sufficient with finance, administrator and other skills all available in-house, no outside consultants. 3, there must be close cooperation of the board with 4 other organisations: hospitals, public health, social services, local authorities. Problem is solved with a company model. For example, 10 directors on the board, 6 GPs, plus 1 from each of the other organisations. In-house staff to do admin and 3 GPs to do clinical work. The board must conduct audit as well as performance and must include education and training. The board must be accountable to a regulatory body with local links. Chair, I move.
Thank you.